Hello, everyone. Greetings and welcome to another episode on Oral Pathology 360, where we talk about everything that is with the diagnosis of oral and maxillofacial lesions. And it's another lovely day, and I'm very glad to have you here with us. I'm also very glad to have with us Dr. Yes, here he is. Yes, Dr. Jose Amenábar, and I do hope I got your name correct. He is from Brazil, and he is one of those rare people who apparently has been working on burning mouth syndrome, which we know is one of our most difficult diagnosis and an equally difficult management. So, hello, Dr. Amenábar. It's very nice of you to be with us.
Hello, Dr. Mandana. Hello, everybody that is watching us. Thank you very much for the invitation. It's been a pleasure for
Welcome.
me to accept and to be here with you today.
Thank you so much. A pleasure to have you here. So, with that, we shall just go on and watch the recording of the lecture, which ensures we do not have any problems. And then we will have the discussion. As usual, please remember to type in your thoughts and your questions in the chat. Okay, we'll catch up again in a few minutes.
Hello, I am Professor José Miguel Amenábar from the Federal University of Paraná in Curitiba, Brazil, and I am truly honored and delighted to be here today. First and foremost, I would like to express my heartfelt gratitude to Dr. Mandana for extending the invitation and giving me the opportunity to speak before you all. It is both a privilege and a pleasure to be here with you today and talk about unveiling burning mouth syndrome from diagnosis to treatment. Throughout my lecture, I hope to provide valuable information and to contribute to the ongoing exploration of BMS. Once again, thank you very much, Dr. Mandana, for your kind invitation and for your continued dedication to advancing knowledge in our field. Now, without further ado, let me start the lecture. Today, I have three goals in mind. First, I would like to explain what is burning mouth syndrome so that you can understand it. Then, I would like to explain the essential steps and criteria involved in correctly diagnosing BMFs. And finally, I would like to explore treatments available for treating BMS patients. So let's begin answering the question, what is burning mouth syndrome or BMS? This is a very important question because we need to know what is it in order to be able to treat it. In few words, the best definition for burning mouth syndrome is that it is a condition characterized by a persistent burning or scalding sensation in the mouth, in the absence of any visible abnormalities. This final part, the absence of any visible abnormalities, is very important, and I would like you to keep this definition in mind during the lecture. Well, burning mouth syndrome is characterized by burning pain in a normal appearing oral mucosa, lasting at least 4 to 6 months. The condition is idiopathic, and the underlying pathophysiology is not well understood. The patients with burning mouth syndrome commonly experience changes in the gustatory function. BMS, it is usually seen in females, typically in the perimenopausal and postmenopausal periods. And, like I said before, the diagnosis is made clinically after other etiologies of mouth pain and changes in gustatory sensation are ruled out. Some studies have shown an association of burning mouth syndrome with axis 1 and axis 2 psychiatric disorders or psychiatric illness, structural and functional changes in the nervous system, and disruption of the circadian rhythm. By the way, the disruptions in the circadian rhythm affect pain perception and mood, and this can disrupt as well the hypothalamic pituitary adrenal axis. In 1989, LaVey and Lewis categorized burning mouth syndrome into three categories based on fluctuations in pain severity over a 24-hour period. Type 1 patients typically have no symptoms on waking up and progressively worsen throughout the day with variable nighttime symptoms. Type 2 patients are associated with chronic anxiety and display symptoms throughout the day. Finally, type 3 patients display intermittent daytime symptoms and may have periods without any symptoms. The etiology behind burning mouth syndrome is not well understood. Multiple theories exist regarding the underlying etiology, and most people believe that the condition to be multifactorial. As previously stated, the disease has a higher prevalence in peri and postmenopausal women, which supports the theory that estrogens plays a role in the underlying process. The decrease of estrogen's level can lead to the atrophy of the oral mucosal tissue, which may leave the area more susceptible to inflammatory change and the development of symptoms of burning mouth syndrome. Another theory says that in some cases, the infection may precede the development of symptoms, and certain pathogens are more commonly found in patients actively suffering from burning mouth syndrome. These pathogens include Candida, Enterobacter, Fusospirochetal, Helicobacter pylori, and Klebsiella. Systemic conditions like anemia and diabetes may also cause symptoms related to burning mouth syndrome. Another theory states that there is an association with certain irritants, including dental materials such as mercury, amalgam, methyl methacrylate, cobalt chloride, zinc, and benzoyl peroxide. Also, certain food allergies, including peanuts, sorbic acid, chestnuts, and cinnamon, have been related to burning mouth syndrome. And another theory says that there is a connection with patients with neuropsychiatric conditions, such as major depression, chronic anxiety, and mood disorders. The most common association is with a major depressive disorder, and it may follow acute symptoms or share an association as a comorbid condition at some point in the patient's life. As you can see, in these cases, multiple theories may have led to multifactorial causes. For this reason, in 2003, Scala et al. Introduced the concepts of primary and secondary BMS. Primary or true BMS means the burning mouth syndrome that is idiopathic, and secondary or fall BMS, which be the resulting from identified precipitating factors. The difference in these concepts allows for a more systematic approach to manage the patients. When thinking about epidemiology and burning mouth syndrome, BMS is much more common in females than in males, with a 3 to 7 times higher occurrence in females. The condition is essentially non-existent in children and rarely seen in people under 30 years old. Overall, the prevalence of burning mouth syndrome is thought to be around 4%. Unfortunately, the pathophysiology behind burning mouth syndrome is poorly understood and may be related to psychogenic or neuropathic pathways, or even both. Disruption in the circadian rhythm, chronic anxiety, disruption in the hypothalamic pituitary adrenal axis, irritants or allergies or infections, and systemic conditions, including diabetes and anemia, are thought to contribute to its development. Now, the underlying type of the pain conduction is likely throughout the trigeminal distribution, and there is evidence of histopathologic changes in the nociceptive nerves in patients displaying symptoms. Studies also show changes in taste perception and hot and cold sensation, which may have reflex hyperfunction to closely related nerve hypofunction. Also, mechanical damage from bruxism, clenching, and tongue thrusting may initiate symptoms and psychological conditions such as anxiety, depression, or stress, most likely exacerbate the burning symptoms. When we think in the diagnosis of burning mouth syndrome, we must all agree that it is a diagnosis of exclusion. This means that in order to have the diagnosis of burning mouth syndrome, first we have to exclude all other conditions such as oral lesions or systemic conditions or diseases that the patient may have in order to have a clear diagnosis. This means that when taking a history, we clinicians should rule out organic causes of oral pain. We must investigate the onset and the duration of symptoms and associated medical conditions, medications, and history of oral prothesis. We must also remember that the absence of oral lesion is mandatory to diagnose burning mouth syndrome. This means that only after ruling out local and systemic causes of burning symptoms can the patient be considered as having burning mouth syndrome. So, in order to have the primary BMS or the true BMS, we need to do a very good clinical examination. We need to see if the patient have any oral lesions. We need to do the test for salivary parameters. Sometimes we need to ask for hematological tests in order to see if the patient have any hematological alteration. Also, we need to search for any nutritional deficiencies or hormonal changes, or if the patient have some parafunctional habits or any systemic conditions or any allergies. And the management of burning mouth syndrome patients is very complex. And more than one treatment modality is often required. It is also important that the patient should be aware that complete resolution of symptoms is not always possible. Sometimes in our clinic we ask the patient to give us a number from 0 to 10, referring to the pain that she or he is feeling. And then we explain that we can reduce the number, but that it will be very difficult to reduce it to 0. Now, the current management option includes topical and systemic medications, cognitive behavioral therapy, and low-level laser therapy. Regarding topical medications, the first medication available is capsaicin. It is an analgesic that has been used as a desensitizing agent that acts on the sensory afferent neurons to manage neuropathic pain. Capsaicin have proven to improve burning symptoms compared to placebo in several studies. However, increased burning sensation just after its application is a common complaint, and sometimes this limits its use. Now, another topical medication we often use is topical clonazepam, and it successfully improves BMS symptoms. It is applied by sucking a tablet of 1 milligram 3 times per day, at least for 2 weeks. However, Symptoms may come back if the medication is discontinued, and it can cause dependence. Also, some patients can complain of side effects, like, for example, fatigue or dizziness. Interestingly, unconventional topical agents like chamomile mouth rinses have reduced burning mouth syndrome. Also, 70% aloe vera gel applied 3 times per day seems to effectively decrease the burning symptoms, especially in the tongue. Sometimes people have tried topical anesthesia like lidocaine, but due to its short-term effect, it is not considered an effective treatment option. If we need to use systemic medications, the two best options with strong scientific evidence are clonazepam and capsaicin. The most common is low doses of clonazepam, around 0.5 milligrams per day, are frequently prescribed for treating BMS pain. Systemic clonazepams relieve BMS, but uh, it does not improve taste dysfunction, xerostomy, or even mood. It looks like a good option for short-term treatment, but chronic use of systemic clonazepam has not been deeply studied. So we need to see if there are any side effects of using clonazepam for long periods of time in BMS patients. Now, systemic capsaicin can also improve BMS symptoms, but it should be prescribed with caution because of its side effects, which include gastric pain. The regimen consists of capsaicin 0.25% capsules 3 times per day for 4 weeks. Another treatment or management options for burning mouth syndromes are behavioral modulation and low-level laser therapy. In behavioral modulation, the patients learn to focus on breathing and muscle relaxation in order to alleviate pain. They also learn to eliminate destructive thoughts, and they stimulate the patient to coping. This means to adapt to the pain, and with time, the patient will not feel any more pain because it will adapt to it. The patient will learn to live with the pain. Now, the low-level laser therapy stimulates the production and secretion of serotonin and B endorphins and decreases bradykinin secretion, alleviating burning mouth syndromes. Low-level lasers also inhibit the depolarization of C fibers, responsible for transmitting pain and heat stimuli. It seems very promising. However, standardized treatment guidelines for low-level laser therapy in BMS patients are still needed. And to finish my lecture, we must all agree that BMS is a very difficult complaint to treat. It's very hard to treat patients and cannot offer um, any treatment that can help them to relieve their pain. Sometimes the treatment works, sometimes it doesn't work. Also, sometimes BMS can remit spontaneously, or it can improve moderately, or even worse in time. So we must know that it significantly impairs the patient's quality of life. And since the etiopathogenesis is yet to be understood, the treatment is a challenge. So we need to focus on more research in order to find different and better options to treat our patients and to improve their quality of life. These are the references that I use in this presentation. once again, I want to thank Dr. Mandana for the invitation. And this is my email in case you want to ask me any questions in the future. Thank you very much and have a nice day.
Yes, that was a very nice lecture. Um, it's really interesting to see um, how undefined this topic is and how much of a challenge is still there to see, or rather to be able to deal with these patients. But very well described and very well collected information there. So, just to remind everyone, please put in your questions and your thoughts in the chat and we shall get to them. Yes. So, I don't know if that's the right way to read it, but
Mhm.
that is Geronimo saying buongiorno. Is that the right way?
I think so.
So, okay, buongiorno.
Let me say to him, Buenos dias.
Okay, right. Okay, Dr. Nasser, hi. And Dr. Osmani, Dr. Amit, Dr. Subodh. Very nice to have all of you all here. Okay, and I think we have a comment here.
Mhm.
Yes. So here we
Oh,
have one from Dr. Subodh. Are there any specific biomarkers associated with BMS?
okay. Thank you very much, Dr. Subodh, for the question. I think that this is a very interesting question because, as far as I know, we don't have any specific biomarker. I know that some people have studied cortisol. I studied cortisol myself, like 15 years ago, and related to anxiety and BMS patients. And I found that there is an association between anxiety, BMS patients, and high levels of cortisol. But when we think about the specific biomarkers, it is very difficult to search for any specific biomarker. Uh, what I think about biomarkers is that maybe we can think of a panel. I mean, like 5 or 6 or 7 biomarkers in order to try to identify the patient with BMS. However, I don't know if a specific or a panel of biomarkers could help us to do the diagnosis because the biomarkers are used to diagnose BMS. And I think that the challenge that we have is not the diagnosis, is the treatment. So I think we need to try to research more alternative treatments or better modalities to treat these patients.
Okay, let's see that. Yes, that's Geronimo again saying good morning, good morning. Okay, we have one more question from Dr. Segar. Uh, what are the symptoms often seen in patients with BMS?
Okay, thank you, Dr. Ravitra. Uh, Basically, BMS patients they complain about pain in different parts of the mouth, especially in tongue and lower lips, but also they complain of xerostomy and taste alterations.
Right. Um, yes, Dr. Geronimo. Excellent presentation with the quality that Professor Amenábar always has.
Oh,
And with a very clear English. Yes, that's true. Very
no,
clear English.
thank you very much, Jeronimo.
Yes. Dr. Ashwini says, lovely presentation. Which of the treatment regimens worked best in your patients?
Thank you, Dr. Ashwini. Here in Brazil, in our clinic, usually we start with chamomile mouth rinses. And we know that sometimes it has like a placebo effect, but we also tell the patients that we need uh, to follow up them more closely. We explain the patient that we know that they have pain. Sometimes they came from different medical clinicians or dentists saying that they don't have anything, that is something from their head. So we explain that we know that they are feeling the pain, and we can try to lower the level of pain. Uh, Sometimes we use a visual analogic scale, VAS, and sometimes we just ask them for a number from 0 to 10, and then we explain them that we can lower that number, but that we do not think that we can reduce it to 0. Uh, Sometimes only talking with the patient, that helped us, help the patient a lot, and they come back like 2 weeks later with a lower level of pain. Uh, Sometimes we need to treat them with clonazepam. That will be the second step. I think like 2 years ago we start. No, like 4 years ago we start with alpha lipoic acid, but we didn't get that too much good results with that because we have a lot of side effects, especially gastric effects. The patients complain of a stomach ache or feeling that the gastric mucosa was burning. So we stopped using the alpha lipoic acid. So we start talking with the patient, chamomile mouth rinses, clonazepam, topical clonazepam. Also, we are doing a lot of laser, low-level laser therapy, but we know that we need more research in that area to standardize the guidelines for lower level laser therapy. But our experience is that.
Right. Okay, we have Professor Joss, very succinct, true. And he has a question. Why do we often see fissured tongues in BMS patients?
Oh, that is also a great question, Dr. Joss. Uh, Well, I think BMS and fissured tongue are different things. I think that patients who has fissured tongue can have burning mouth sensation, but I will not include those patients as patients with burning mouth syndrome. Probably they have an atrophy or the tongue surface, it's or the papille from the tongue surface, they were very close to the or mouth surface, and they can feel more things like cold or hot, um, or condiments, and they start feeling pain, but I don't know if I will include them as real burning mouth syndrome patients. I think that I will put them in secondary BMS, thinking about the Scala classification.
Right. Okay. Let's go on to okay. I Unida Dental. Is all I'm going to read from there. Okay. good, good
Unidad
morning.
dental
Yes.
especializada. It's Spanish, yeah.
Okay. Okay. When there are no psychological factors that are causing it, what complementary tests should be sent?
Well, actually, I found very difficult to not have any psychological factors. Um, I may have a bias, but I think all BMS patients have some kind of psychological factors like anxiety or at least stress. But complementary tests will be hematological tests or some saliva tests to see if they have a reduced saliva flow rate. Um, Tests to search any nutritional deficiency like vitamin B complex or iron. I'm thinking maybe of some kind of anemia that could be a trigger factor. Also, some glucose test to see if the patient has any modification in the uh, glucose level, maybe a pre diabetes or diabetic patient, something like that.
Right. So, but I always find sometimes when we talk about psychological factors, everyone takes for granted that they are not real.
Yeah.
I think we need to specify that they are still very real,
Yes.
just because it's very difficult for us as doctors to identify a disease which has no symptom, which has
Mhm.
no measurable manifestation.
Yeah.
But that does not mean it's not there.
Exactly. Exactly. And I think that is the challenge. If we can find a cause, then we can do a treatment. But since we don't
True.
find a cause, we don't know how to treat those patients.
Those patients, exactly. And there are other, in fact, I have read somewhere, there is something called a burning foot syndrome.
Hmm.
May not be a syndrome, but it's a burning foot. So, so that the feet literally feel like they are on fire.
Hmm.
Again, it's more in women, and it has been found to be associated with BMS.
Mm.
So, I mean, I don't know. It just, could it be just that some form of a vascular extremities and vascular problem?
I think maybe it could be some alteration of the vascular or some vascular disease with burning symptom manifestation. Maybe, yes. Uh, that is why it's very complex. It's very difficult
Complex,
to.
complex, yes. Because, like you mentioned, although I can understand it being related to menopause and to, if it is related to menopause and to menses, is that basically there are estrogen receptors in the oral cavity.
Mhm, yes,
So they get affected every time there is an up and down with the hormones.
yeah. But
Yeah.
sometimes you give estrogen reposition for women, and they don't have any BMS anymore. And sometimes you lower the estrogen therapy, and they don't have BMS anymore. So
It's very difficult.
it's
Yes, I
difficult.
can understand. Then you have to understand that menopause itself is a very complex thing that still no one has
Yeah,
figured out.
yeah.
Right. So let's
We always
get
said that
back.
we don't have a disease. We have patients, so we need to treat the patient. We
Very
need
well
to do
said.
specialized and specific patient treatment. We
Yes.
cannot put everybody in the same into the same group.
Very well said. Yes. Okay, we have here Dr. Nasser. Oh, yes, Dr. Nasser is our viewer I was talking about who manages to watch us in the middle of the night from the US. Right. Okay, so it's always very nice to have him here. Let's see what is he saying. Okay, very nice and informative. Thank you. Your thoughts on topical rinse expectorate of clonopin. He
Mhm.
has I have positive results, but only taking the edge of burning.
Exactly. Yeah. We have the same result, only taking the edge of burning. Hmm. And sometimes when the patients stop using the topical rinse, they start complaining again about the symptoms. Yeah.
Dr. Amit. Hi, Amit. A few case explanation, please. Are you looking for case presentations in these cases? We will have to have another session.
Okay.
Unless you can just offhand explain a case, I don't know.
Uh, well, we can give some time to Dr. Amit to explain
What is his question
what is
exactly?
his
Yeah.
question. Yes.
Yes. Okay. That will be better. So let's just move on and we will come back to him once he has explained.
Mhm.
Dr. Osmani says, is the diagnosis only clinical?
Yes. Yes. I think so. I think so. First, you have to exclude all the other factors that can mimic BMS, and that is what Scala said about the secondary BMS. If you can find a factor, probably it's not real burning mouth syndrome. Probably the patient have a burning mouth complaint that is associated with another cause. Now, when you cannot identify any cause, so you can diagnose the patient as burning mouth syndrome patient. So yes, it's only clinic. Sometimes I said that it is like like a leukoplakia. You said that the
Right.
patient has a leukoplakia where you cannot diagnose this white patch like any other disease.
Disease.
For me, burning mouth syndrome is the same. If you cannot identify any cause that is making the burning complaint of the patient, so you have to diagnose that patient as burning mouth syndrome patient.
I was actually thinking exactly of the same thing of leukoplakia when the lecture was going on. Yes, we have something from Geronimo. Yes. Regarding the alleged role of local factors on BMS, in type 1, it has been proposed that parafunctional habits such as a swallowing disorder lead to repeated and light mechanical irritation.
Yes, because patient with bruxism or any parafunctional habit, it's stimulating constantly the mucosa. So you have like a chronic, repeated inflammatory irritation, mechanical irritation. So yes, maybe
Right.
that can
And
overstimulate the mucosa.
there's a follow up to his statement.
Okay.
This explains why a given patient is asymptomatic early in the day and gets worse throughout the day. What is your take on this? If so, how do you approach it?
Well, it's difficult it is difficult to tell the patient that he or she has a parafunctional habit. So sometimes we say to the patient, did you pass your tongue in the lips? And the patient says, never. It's just it's talking with you doing that. So it is very difficult. So you have to like maybe talk with her relatives or friends or families and try to find out if the patient have any parafunctional habit, or ask the patient and tell them to watch and to see if they are doing anything like pushing the tongue through the teeth or some other habit, or just biting the tongue or biting the lips.
True. Yes, he has one more. Some. Do you recommend having a diary with a visual an
Yeah.
analogy scale? Do you
Mhm.
believe it's useful? Finally, what is your opinion on dental materials in this disorder?
Okay. Jerome, I think that is an excellent question because sometimes we tell the patient, please do this diary and use the VAS daily and put the level of pain that you are feeling in that day. I think that may help the patient to see that the symptoms are improving. I mean that they are getting lower. Uh, but we can also think that maybe it's a placebo thing. And about dental materials, research says or study says that you can have allergies, but specifically to amalgam, I would think that the patient may have some lichenoid reaction. And if the patient has some lichenoid reaction, I will not include that patient as a BMS patient. I will first treat it as a lichenoid reaction. I treat the lichenoid reaction, maybe substituting the filling with a resin or something like that, and follow up the patient.
Right. Okay. We have. Oh, hi, Sandhya. Then we have Professor Hill saying something. Oh, I think this was Clonopin, is it clonazepam? Where did that come up from? It was in
I think
someone's
somebody
question.
asked about clonopin. I thought it
Yeah,
was clonazepam. Hmm.
yeah. And Dr. Amit. How to manage doctors or their family members having BMS?
Okay, I think the family members must help the patient that have BMS, especially because sometimes the patient goes to different kind of doctors, like physicians or dentists, and sometimes everybody says, "Though you don't have anything," or "We don't found anything," and the family members start saying, "Oh, that is from your head. That is from your head. Like you are getting nuts." And so the patient, since I think it is related to stress, I think the patient got more stress and start developing more and more and more burning mouth sensation. So she or he will start complaining more, and that is why I think it's very difficult for them. And as soon as they found somebody that tells them, "Listen, we know you have a real pain. You know that we cannot see anything different in your mouth, but we know that you have this pain, and we will try to help you." That really comfort the patient. So we need to talk with the family members and also explain to them that the patient has real symptoms and that we need their support and that the patient need their support. Also, one thing that we tell a lot the patient is not to worry that it is not cancer, because a lot of patients are cancerophobic. Sometimes they think, oh, maybe I have some cancer, something like that. So I just tell them, we will try to improve your quality of life. uh, I cannot promise that uh, we can improve it, but I can promise that you will not die from cancer because of this. This is not cancer. And a lot of patients just feel better with this kind of talk.
That is very true. Cancer is one of the best known, oral cancer, I guess, is one of the best known oral problems now. And people will be worried, yes. Okay, Dr. Subodh. Any role of intraoral submucosal injections in treatment of PMS?
Not that I know. Not that I know really. I can search for it, but as far as I know, no. I don't know if anybody in the audience have any experience with that. That would be great if they can share.
Okay, he has modified that to ask, is there any role of submucosal of steroids in management of PMS?
Hmm. No, no. As far as I know, no.
Yes. Hello, Dr. Daniel. He is asking, congratulations on the brilliant and objective presentation. As you
Thank you.
have pointed out, many patients with psychiatric disorder present BMS. Have you managed with suicidal patients? This is so
No.
challenging.
Yes. I think it will be a challenge, but no, no. Thank God I had never managed suicidal patients.
Yes, that would be a very difficult situation.
Yeah.
Okay, sorry, that we have already done. Professor Josh says, yes, alpha lipoic acid does not work.
Yeah.
And Dr. Amit is asking, what is your protocol for LLLT?
Okay. Well, we use the infrared laser, right, in uh, 808 nanometers, and sometimes we vary from 2 joules to 6 joules. So we started with 2 joules, 15 seconds per point. So we put it in different points of the tongue, our lips, and for 15 seconds. Sometimes we need to put more gels. Maybe if the patient still with complaint and with the use of the VAS scale and it doesn't show any improvement, we try to put more energy, like 4 or 6 gels. But as I said in the lecture, it's very uh, empiric. We need more studies with higher participants in the groups, so we can establish a specific guideline for BMS and low level laser therapy.
Right. Yes. More studies is the main thing. Okay, Dr. Paulo is asking, what is the bigger challenge of the diagnostics?
Oh, Dr. Paulo, I think uh, the challenge is to find the cause. I still think that if we can find the cause, we can think about the treatment. Because right now, what we are doing is trying to treat the symptom only, but we are not treating the disorder or the disease. I mean, so the challenge is to know what is the etiology and what is causing BMS. I mean, if we can set that we are 100% sure that BMS is associated with psychological disorders, so we can treat the patient with some psychological treatment. I mean, with a psychiatry or psychologist. But since we don't know if it is psychology or neuropathic, for example, we don't know how to manage it.
True. Has hypnotherapy been tried? Just a thought. Okay, let's see. Okay, Dr. Subodh is now clarifying. The thing is that, yes, we use steroid injections in the treatment
Oh,
of burning mouth associated with oral submucous fibrosis in the early stages. So, which is why that was the question he was asking.
okay, great, great.
Right. And then he has one more question. Any
Mhm.
role of biopsy in the diagnosis of PMS?
No, we usually don't do any biopsies for the diagnosis of VMS. I
Yeah, I
mean,
guess only unless you are ruling out anything else.
yeah, yeah, because if we don't have any lesion, we don't have any place to biopsy. Where we are going to do the biopsy? I mean, the patient can complain, I have this pain in the tongue. Okay, where? Or in my lip. So it will be very difficult to try to take some sample and what we will be looking for. I don't know. So I don't know if it is a good alternative. Not a good idea. I think it could be a good idea, but I don't know what will we be searching for. So
Yes, quite. And Dr. Paulo. Okay. Are autoimmune lesions seen in conjunction with the syndrome? And he wants you to give a high for Brazil. Okay.
okay, automulations is in conjunction with the syndrome. Uh, Maybe lichen planus. It could be not an autoimmune lesion, but um, it could be like an autoimmune disorder or uh, immunity mediated lesion, lichen planus. Uh, but once again, if I see that the patient have lichen planus, I will not diagnose that patient as burning mouth syndrome patient. I will say that the patient has burning mouth symptoms associated with lichen planus or with
Yes.
any other autoimmune lesion. And he's asking to give him a high for Brazil, so I will try to do it in Portuguese. Então, hola para todos os brasileiros. É muito bom tê-los
Okay.
aqui.
Cool. Okay. And we have Professor Joss. Yes. I recently learned that burning vagina or labia also has been recognized. I still think that psychological factors are real. Have the supplementation of magnesium and zinc been investigated?
Yes, sure. Uh, I read some papers, I think like 15 years ago or something like that, that they used to call stomatovulvodynia. Stomatovulvodynia. Yeah, the
Yes.
patient has complained in the oral mucosa and the vagina mucosa, this burning sensation or burning pain. Yeah, exactly.
Yes.
Vulvodynia, exactly.
Yeah. Then Dr. Nasser is saying thank you and thank you for watching. And
Thank
we
you, Dr.
have,
Nasser, for watching.
yes, and we have Dr. Daniels. Great presentation, Prof. Please comment on a holistic and multidisciplinary team approach to the diagnosis and management of BMS. That is, psychologists or psychiatrists, neurologists, neurosurgeon, and I guess us.
Yes. No, that is a great observation from Dr. Well. I think that the multidisciplinary approach to treat these patients is fundamental. Yeah. Uh, and I think sometimes us as dentists, we still like to work alone. We need to open our mind and say, no, we have to work as a team with, I think, especially with the neurologists, yes, of course, because maybe it is a neuropathic pain, and with psychologists or psychiatrists because, as we can see, basically 99% of the patients have an uh, psychological factor associated.
Okay. Dr. Subodh says, in short, patient with BMS gives BMS to the dentist.
Yeah, I think
Okay.
for us it's frustrating having a patient and not be able to help the patient or uh, to help the patient get better. I think sometimes the patient adapt. I mean, he has this coping mechanism and adapt to the pain. It's not that the pain goes away. It's just that the patient adapt to the pain and start living with the pain.
True. Professor Hill. So,
Yes, Dr. José
I
saying
now
that
and
TMJ
then
issues. Mhm.
diagnose TMJ issues in BMS patients, suggesting that unconscious parafunctional habits go hand in hand with BMS. Yes.
Yes, that is why all the parafunctional habits must be searched, and also we can do some TMJ examination. Mhm.
Right. Yeah, I guess once the if the TMJ is affected and for somehow the natural clearance or the natural space is lost,
Mhm.
it would
Yeah,
cause more trauma to the mucosa. Okay. Dr. Joss, if you read the literature about paramenopausal deficiencies, issues like magnesium and vitamin D levels come up. Recently, after COVID 19, the optimum levels of vitamin D have been adjusted upwards. Oh, interesting. I did not know
interesting.
that.
Hmm.
Yes, I did not know that. We'll have to find out what those levels are. Okay. Yes, Dr. Subodh says, thank you, Dr. Jose, for an excellent presentation.
Thank you, Dr. Suboth. Thank you very much.
And Dr. Daniel says, one last question. Have you experienced a better response to clonazepam tablets as opposed to oral rinse of clonazepam?
Not really, not really. Sometimes we ask the patients to put to use clonazepams in drops, so can do some mouth rinse of clonazepam. Sometimes the patient have the tablets and suck the tablet for a minute, so we haven't seen any difference. No.
Now, I have one question. Is
Mhm.
since you mentioned that capsaicin is good, basically, has anybody studied populations who basically have a diet that is very heavy on spice,
Hmm.
or who ingest more chilies
Yeah,
to see if they have less number of cases?
I I really don't know, but maybe we can ask some Mexican friends and see.
Yes,
They use
Mexican,
Tabasco
Indian.
and
Yes,
Indian.
I was
Yeah,
actually looking today and I could not find any data, specifically epidemiological data on
yeah.
India. Yes,
Mhm.
so it's very interesting, and I don't think there are many countries with their own data. It should be something interesting to find out.
Yes. Maybe what they are doing, or what they try to do with capsaicin, is also to give a higher level of pain. So when the capsaicin effect goes
Yes,
down, the patient just adapt to that kind of pain. So
yes,
make a difference of pain
yeah, counter
acceptance.
irritant.
Yeah.
Yes, quite. Okay, so we will take this as the last question. Okay, Dr. Wall, could myofunctional therapy have a role in the management of BMS?
I think it could. It could if you have any factor associated with the muscles. I think maybe the patient can have myofascial pain or something like that. Maybe the therapy can work. Yes,
Yes, sorry.
that is
Okay,
a good
last.
idea for research. Yeah.
So Dr. Daniel says thank you, and maybe oral medicine practitioners from here in Brazil could help. They eat a lot of spicy food there as well.
Yeah, that is right, Daniel. In Bahia, they like
Okay.
spicy food.
Yes, these are all these very interesting regional things that we don't necessarily check actually, but they would be very interesting. Okay. All right. I really should stop now. Okay. So Professor Jaws says, I think that the effect of clonazepam, either in tablet or liquid form, is due to the quick sublingual absorption, and then the patient benefits from the benzodiazepine effect.
Yes, yes, yeah, I
True.
agree. Hmm.
Very true. Right. So let's go on, and thank you everyone for the wonderful discussion and all your contribution. And now I shall say thank you to you for the uh, excellent presentation. Sorry, I'm distracted because something was happening here. That happens periodically when I'm watching what is happening in the background. Okay, yes. Thank you so much. That was truly a very interesting presentation, and I think we had an excellent discussion. So that itself tells you that it was very, very good and very timely. Thank
Okay.
you so much.
Thank you very much once again, and thank you very much for all the audience and for the chat. Yes, I think it was a wonderful time here together, making science.
Yes, absolutely. So I'm going to remind everybody, if you like the lecture, please do remember to hit the like button, because that's how Professor Jose also will know that you liked his lecture. So that is one thing. And then let's go on and tell you what is next week. So, I think last week or maybe the week before that, I spoke about empathy in healthcare, or rather in diagnostics in healthcare. Now, next week, it seems a natural continuation of that is to talk about how do we deliver bad news with compassion. I know it is not that much for us in dentistry, but definitely for us in the diagnostics half, it is very much there. So, that is going to be next week in a part of the thinking outside the box. And with that, I do hope to see all of you. And thank you, everybody, for being with us, for the appreciation that you have shown for the lecture, and of course, Dr. Jose for being here and for the great presentation. Bye, everyone. See you all next week.
Bye bye.